It's lovely to see so many of you here this afternoon for this afternoon's parallel session on Frailty, What's in it for me? Welcome to all of you, including those that are joining us remotely. It's really great to see so many of you. I've been asked to share and to remind you about a couple of things which I know some of you will have heard from this morning's first session, but I've asked to remind you that a recording of this session will be available in 10 days' time on the new online platform, and you'll find details in the conference brochure that you've been given. If you are joining us remotely, please can you put any questions you have in the question and answer box under the live stream, and we will be paying attention to those. We have an iPad in the room. For everyone else in the room, if you've got questions, you're more than welcome to put them in via Slido, and they'll come up on the iPad as well. But we actually want this session to be as interactive as possible. So if you want to hold on to your questions, we will have roving mics, and you'll be able to answer them as we come round. So completely your choice. Please do ensure that your mobile phones are silent, and in case of an emergency, an announcement will be made asking everyone to evacuate the building. I really hope this doesn't occur, and head to the nearest available exit. The muster point is between the SEC Centre and the SEC Armadillo, and no one is to return to the building until official announcements have been made by the SEC. That was a big start. Now that housekeeping has been addressed, we can move on. So welcome, I'm Julie Kinley. I'm the Research and Clinical Innovation Project Lead at Hospice UK, and I'm delighted to see such a full room. During the next 75 minutes, you will get to hear from Kat Sullivan. Kat, give us a wave. Helen King, another wave. And Joy Ross, a final wave. So for those of you who don't know Kat is one of the Senior Quality Improvement and Clinical Practice Leads at Hospice UK, currently managing the Extending Frailty Care Programme and supporting the Resilience-Based Clinical Supervision Programme. Helen, in the middle there, is a consultant nurse at St Christopher's Hospice, and during the last 3 years she's worked with Professor Caroline Nicholson and Professor Heather Richardson, embedding aged attuned palliative care, which many of you may have heard of, throughout St Christopher's, and cascading this into the primary care teams and beyond. And finally, at the end there, no means last, we have Dr. Joy Ross, who is the medical lead at St Christopher's Hospice. She has many years of experience in palliative care and has a specialist interest in developing services for older people living with frailty. We thought if we did the introductions to start with, at least you'd know who you were looking at. So the 75-minute session we've got, I'm sure, is going to whiz by. And at the end of this 75 minutes, we hope that you'll be able to define frailty and start to be able to identify people living with frailty. You'll get the opportunity to hear the voice of those living with frailty, and also to consider your own role in relation to provision of care for those living with frailty. And what's also really important is that we hope you take away the message that we need to ensure all those living with frailty have the opportunity for a conversation about what matters to them, that is then acted on, but then also revisited, and to ensure that measures are taken in agreement with the person living with frailty to minimise functional decline. So how are we going to achieve this afternoon? I'm going to be setting the scene. You'll then be hearing from Kat, who's going to gather your perspectives, and that's going to be followed by a presentation by Helen and Joy, who are going to be presenting to you the perspectives of those living with frailty through looking at the Palliative film, and I quote, providing some provocation with panel discussion after that. That was their words, not mine. And then we'll head for a close. So what is frailty? If you read the literature, it says it's a distinctive health state that can be related to the ageing process, in which multiple body systems gradually lose their reserve. People who are frail find their usual inbuilt body reserves are unable to respond to a minor stress or illness. So it's quite clear, and I'm sure most of you can picture somebody that might remind you of that. So if we know what frailty is, how can we identify it? I guess these two don't need any introductions. Many of us would have been quite surprised, I think, by how quickly the Queen died soon after this picture was actually taken. And my reason for showing it to you is really to highlight how important it is that we pay attention to what came before, to the past, as well as what we're seeing in front of us. And we know that Prime Ministers turn around quite quickly. So if we were to look at the slide of the Queen welcoming in the previous Prime Minister, the difference between those two images is really stark, just even in her physical appearance. So is observation enough, or do we need to do more, or should we do more when we're trying to identify people living with frailty? So people living with frailty can be identified, I think, through their personal circumstances, or by the presence of pre-specified criteria, or through an assessment using specific tools, some of which will be very familiar to many people in the audience, I'm certain. So in relation to personal circumstances, I think we'll all know professionally or personally, perhaps somebody who might have had a chest infection and they've recovered from that, but perhaps their mobility hasn't gone back to what it was like before they got that chest infection, and that new level of mobility becomes their new norm. So that's what personal circumstances is referring to. Or it might be through assessment, and there are two main ways of doing that. It might be by looking at the presence of pre-specified criteria. So, for example, 3 of the following: unintentional weight loss, self-reported exhaustion, weakness, slow walking speed, and a low physical activity. Or you might be using specific tools. So I've just put this up as an example, the clinical frailty scale. But again, all of those are valid for different populations and in different ways, and we all need to be quite sure about how to use those if we're using one of these tools. So we started with frailty, what's in it for me? And I think Joy and Kat and Helen will be very much discussing that and considering your views for the rest of this session. But before they do that, I just wanted to highlight a couple of things. So whilst frailty is not an inevitable consequence of ageing, it does increase as age increases. So 4% of people aged 65 to 69 are frail, 26% of people over the age of 85, and it rises to 65% of people aged 90 or over. And then I think to talk about that in terms of the UK and English population, in the UK, the proportion of the population aged 65 and oldest is the fastest growing. There are and will be increasing numbers of older people, both living with and dying from frailty. And so in England, in 2018, of the 505,889 deaths, 428,770 of those were people aged 65 and over. So I would say possibly that your caseload and the workload that you are actually doing at the moment already incorporate care of those living and dying with frailty. And on that note, I'd like to hand over to Kat.
So, hello everybody, my name is Kat. You are so welcome here today. We're going to run through some Slido questions now, so hopefully you'll have had a chance to look at the initial slide at the beginning. Are there many people who haven't had a chance to input the information from Slido? Should we put that slide up again? So if you could just, as expediently as possible, go to slido.com, then enter this code, and then select the Alt room. I'll just give you a minute to do that. And don't worry if you can't do it. You can feel free to chat with your people beside you if you want to influence the outcome here. Yeah.
Sorry. It's COP22, not 2022.
Oh, thank you. Well spotted. First day blip. Well done. Thank you, everyone. Did you all catch that? So it's COP22. Okay. So let's go to question 1. So I've come over to the mic and I'm kind of subdued and I didn't have lunch, so I'm not sure how you guys are feeling, but aside from making you do star jumps, I was trying to get this to be energized. So if we have question 1 up, it's a nice easy one. So to what percentage, Stuart, and we got the first question? So to the question, we'll say it to you before it goes up on the screen. To what percentage does your practice involve care of people with advancing frailty over 65? And you will see that your increments are 20%, 40%, 60%, 80% and 100%. So just to get you thinking. So there are very few people who have 100% of their patients, but there's clearly quite a few people who do have quite a number of their patients who have got frailty and who are over 65. But I guess you are a self-selecting audience as well, right? So if we move on to question 2. So for question 2, we're going to ask you to do a word cloud. So the word cloud is, what 3 words do you associate with frailty? You can be putting those in while... there should be... can you... If you go into polls, yeah, I think that you need to move along to question 2, Jules. Not Jules, sorry. Has it gone along to question 2? Yeah. Sorry. Thank you, Niall. So you can be thinking about this. So basically, Let's enjoy this moment. What 3 words do you associate with frailty? And one of the reasons we're asking you about this is because this is a question that gets asked a lot. And we're hoping that we'll be able to show you a comparison at some point during the session. Lovely. Vulnerable, weak. Off to a good start. Old, dependent, cachectic. Fantastic. So you needed that thinking time. So again, I'm just going to set a timer for 1.5 minutes so that we don't kind of go on. Lovely. This is... So for those of you who've used it before, you'll see that the bigger words are representative of the words that you're putting in more often. So we're seeing elderly, falls, weak, weakness, vulnerable, fatigue. So we've got a combination, actually, haven't we, of symptoms and of functional presentations. But I think what you will see, and the exercise is not exactly difficult to interpret, is that they're negatively loaded words. Cool. So in the interest of, so the third question is, what words do you associate with the challenges of caring for older people with advancing frailty as they approach the end of life? So a slightly different question. What words do you associate as the challenges of caring for older people with advancing frailty as they approach the end of life? Ooh, resistance, interesting word. Complexity. Funding issues, resources is obviously coming up big. Skills, interesting. Time. Uncertainty, a word that we see a lot in this context. Multi-layered, I like that. Lovely. Person-centered. So what you're seeing here, at least some of these, are they link up well, I think, with what we do in palliative care generally. We manage uncertainty, we manage complexity, and I think we will hopefully be presenting a case that we actually have the skills. Somebody's mentioned grief. I'd say a couple of people have probably mentioned it, because bereavement support is obviously a really important part of taking care of older people who might have depended on somebody in a partnership for quite a long time and then they are without it. And yes, workforce, critical to managing it. If we're going to be delivering added value, then we need a workforce to support us to do that. So yeah, so we've started to get a sense of what we were all sharing in the room. That we have, yes, frustration. And yeah, recognition. When is the final decline? How do we recognize it? And yes, too late. Too often the care that we're giving is to people who need it way before we get to them. So I am going to end that part of the session now, and thank you so much for, I think it might have been the first Slido of conference, so I'm going to be a bit forgiving, and I hope you are too. Thank you very much, everybody, and I'm going to hand over to my esteemed colleague, Helen King now.
Okay. We'll get there. Hang on, where's the start of my one then? This is always good. The technology is the best bit, isn't it? Slido session. Ha! So, frailty. So interesting, because frailty a few years ago was definitely the new kid on the block, wasn't it? Everyone was talking about it, it was the buzzword, and it's still there. It hasn't changed. But really, we can't go on talking about frailty as if it's something that we are a little bit interested in, but it's not really anything to do with us. We've really got to start thinking a bit more about the actions that we're going to take and the challenges that we're going to address. So it's not new, because Rockwood's scale came out in 2005. So that was looking very much more at front door frailty. So you'll see the Rockwood scale probably on the back of every ambulance. Has everyone seen it on the back of an ambulance? A few nods. This was really looking at front door frailty. How do we stop that revolving door of people going in and out of A&E? And it became a bit of a political issue, because then it looked at frail people as blocking beds in hospitals. So frailty's negative connotations have been huge. But the bit that's been slow, the people who've been slow to come to the party, are end-of-life care. So the last decade has seen an absolute surge in papers about the experience of older people with frailty who are coming to the end of their life. And this is just a sample of some of the studies that are out there. We've got a reference list for you as well. But all these were written in the last 5 or 6 years. So we've got a growing body of evidence that shows that older people with frailty have palliative care needs, and we, as palliative care professionals, can do something to address those needs. So that's not new. That's just current evidence building that we need to keep on doing. So the big problem that we have with frailty, that you will tell me and everyone will tell me, is, yeah, but there's so many of them. And indeed there are, aren't there? Because a third of people who die are over the age of 85. And we've already seen the stats that of those people who are 85, an awful lot of them are going to be living with frailty. So really, frailty is palliative care on an industrial scale. And if we can go in the right direction, we might find out what we can do about it. So we know that age-attuned palliative care, which is something that's been discussed at this conference before, is one way of looking at how we address some of the ways that we can think about changing our practice. So it's about shared care, about working differently with older people, about changing our clinical response. But more importantly, it's about looking at societal change. What do we need to do to make everybody think about frailty and about the fact that as you age, you get closer to dying? And that might sound very obvious to us, but any of those of you who work with older people with frailty will know that that's not what older people with frailty think. Older people with frailty are you and me. We're getting there. We're going to be there, but we don't like to think about that bit. We think that we're going to be the Queen, or Joe Biden, or the Pope, or the Dalai Lama. These are all people who have been in their 80s and 90s leading world figures. Now, I quite fancy that. I quite fancy being the Queen. Quite all right, wouldn't it, for so many reasons, but not the dead bit, maybe. But I quite like the idea that I will be there greeting my prime ministers, and then the next minute I'll have fallen over dead and everybody say, gosh, fancy that. Wouldn't that be just the best way to go? Didn't she really show the way? And the fact that she actually also died of old age. That's something that's still quite new to many people, that she didn't have to die of something. She just lived a long, well-lived life, and then it stopped. Sadly, for a vast number of people, that's not how it's going to be. So we looked at how we could make age-attuned care for people who are older with frailty really come to life in St Christopher's. And what we found was that actually this notion of living well is different than it was 50 years ago, that things have actually changed a little bit over the last 50 years. And that actually now the things that people who are older are facing are social death and financial pain. But there's good news on that. So I happen to sit next to somebody at lunch who's talking in the next session. So I advise you to go along and listen to Emily Pickett, who will tell you that actually there is going to be some light at the end of the tunnel in the spring for DS 1500s to last for a year. So that's quite exciting, isn't it? It's the next session. Carer burden is something that is one of the biggest issues for older people with frailty. And we know that actually for carers, this is a long period of time with sometimes they just can't see the end of the tunnel. And we rely on informal carers for older people so much. We just simply could not do it without them. So we have people who live on the margins of society. The hospice movement was set up in 1967, the modern hospice movement by Dame Cecily Saunders, as you all know. And she was looking at those people who were rejected, dejected, not cared for, shoved to the end of the ward, no one quite knew what to do with them. And she embraced them and started the work that we're all here doing today. Now those people are not the people with cancer, they're still there, but we also have this burden of people who, a burden for them, they're living life at the edges of society. They're not valued. Those words that you put up on the board are all quite negative. We don't put up wisdom. We don't put up a long, well-lived life. We don't think of the beauty in the years of people who are older. We think of the problems. They are a problem. And they're a problem that we decide to do something about. It's interesting, isn't it? Is that what it should be about? The biggest problem that we have is that they are living with uncertainty, and we are uncertain about how we should progress. But it's interesting because the hospice movement's 55. I think that is quite a good age, really. 55, you're still young, you've got a bit of wisdom, a bit of maturity. You're adaptable, you're up for a challenge, you're willing to change. So we're in exactly the right space to look at what we're doing and think about how we can do it differently. Uncertainty is the biggest problem for most people and most families who are looking after people with frailty. We just don't know when death is going to happen. I describe this to people as life on a diving board. Now, some of us, a bit like the Queen, will run to the end of the diving board and do a somersault off the end, and that will be wonderful. Exit done whilst fully living. Many, many people will stand on that diving board. They might take a little walk to the end, look over the edge, think, not yet, no, cold, wet. They'll turn around and they'll walk back. They might spend a couple of years thinking, oh, the diving board's there, but I'm not going yet. Some people will turn around to walk back and fall off because the balance isn't so good. Some people will just wobble on the end for quite a while and then tip over. We just don't know which one they're going to do. It's really, really hard to predict. So that life on the edge of the diving board presents us as palliative care clinicians with a real issue. Because how long do we carry on caring and looking after for somebody who's living with frailty? How long do we keep guiding them and supporting them and helping them? Is it limitless? Is it a short spell? How are we meant to do it? And the uncertainty doesn't help when you have knowledge. So on my way here last night, I got a call from a colleague who rang to tell me that her mother, who has been unwell for a couple of weeks and things have been a bit tricky, and into hospital because it might be reversible, and then out of hospital because it maybe looks not reversible. Actually now, she said, oh, my mum is now dying. She's actively dying, and it's horrible. It's awful. She's got so many symptoms. I don't know what to do. This is a skilled palliative care nurse of many years standing. And she says, I'm listening to all her secretions, and all the things that I say to people are not working for me or my family. There's no one there to help and assist. No one really seems to care. I'm lost. I'm distressed. And she did. It was a real eye-opener for coming here, because she sounded so distressed that it made me feel even more passionate about the fact that we've got to think about how we can do this better, how we can really address the needs of older people, and how we need to listen to what's really going on. So we really have thought about this a lot and asked older people how they feel, what words they associate with frailty. Because actually, funny enough, older people don't want to be called frail either. And they've come up with similar words to you. So victims, slow, helpless, boring, lonely, bad drivers. I don't know why that's in there, but hey. Grumpy, victims of crime. Really not nice stuff. So we've worked with Surrey University, looking at older people with frailty and how they feel and what they think their needs are and what they think ought to be happening. And it was a real privilege to do this. It came apart as part of work that we'd been doing with older people at St Christopher's, and we did this filming during the pandemic. It was actually one of those research projects that, normally it's very hard to get people to sign up. This was easy because people were even more lonely than normal, so they were very keen to be filmed, and they really enjoyed the sessions we had. So this is their voices. This is what they think. So listen, watch, think, and get ready to tell us your views too.
Older people living with severe frailty are nearing the end of life, and yet their palliative care needs are often either unknown or unmet. The PAL-UP study aims to improve the support provided to older people living at home and their carers, to enable the best possible quality of life in those final years. This film brings together the thoughts and experiences of 10 older people living with severe frailty and 4 of their family members and friends. They talk about what and who they feel is most important to them in living their lives well. We have grouped their responses into categories of need, identifying those elements that these older people have described as supporting their personhood, kinship, and comfort. This film was made during the COVID-19 pandemic using an innovative method of recorded Zoom interviews. Participants were supported in person throughout the process by their clinician. And we thank each person for their willingness to share their lives at a time of great challenge.
As you're watching the film, please consider the following questions. How is the film making you feel? What resonates with your own experiences and what doesn't? And finally, what challenges and opportunities does this pose for you and your practice?
You get used to living alone. In many ways, we have to anyway. But the only thing that cripples me is night time.
I'm fortunate I don't get too depressed by my situation, being by myself and alone.
Now I just feel lonely, and sometimes I feel there is nothing in the world for me.
Companionship, someone to talk to, that is the hardest part. Having no one to talk to.
This coronavirus doesn't help at all, because you can't see your own bloody children.
I got the carers, but I want the people who understand me.
I haven't any other family, and with this awful lockdown, it's, you know, just I really do feel that I don't exist anymore.
Thank God, with my family, I don't really need carers or anyone.
I don't know how people get on who haven't got a family. I really don't.
One or other of my children is here most of the week. There's somebody here most of the week.
I mean, I've even had my granddaughter giving me a good old scrub down because I was completely helpless.
She done a whole lot for me. I can't depend on her.
I pay my council tax to Croydon, but my GP is in Bromley, and the services don't want to work together.
And the amount of forms you have to fill in. And they ask the same question over and over again.
You can't just sort something out with one phone call, it then develops into others. So it's, you know, it's not just, it's dad's medication, mum's medication, you know.
If people ring dad with information about an appointment, dad doesn't always understand exactly what they're asking him or telling him.
The worst thing is the reliance on other people.
When you get someone who comes in and doesn't know your habits, they tend to move things. And I said, no, don't move that. Do it this way.
And if people don't do right for me, then that is another worry.
One come to the door. I said, who are you? Oh, I'm his carer. He's a man. Never see him before.
I always assume they want something. Because I haven't seen him for ages.
Perhaps I shouldn't say this, but it feels, sometimes you feel that you can't trust people.
My whole mind is set on getting decent carers. Get that out of the way, and I don't think I'd have a worry in the world.
If I want to go and open with them, I will go. I don't wish to go.
I know I need care, that's obvious, but I would like that care to be here at home.
You're left to you because it's independent living.
Well, I'm an invalid as such, but I can still do things by standing at the sink and washing myself down and all that. That's okay.
If she was in a community environment, personally, I think that would have made her life fuller than it is sitting in my front room.
And the main issue that boils down to with old people is how much money they've got in the bank. Because that's the first question they ask you when you fill in a form.
The care that you get is very expensive. And although they come each day, it's not enough hours.
Dad does need to have somebody coming in, but Dad doesn't want to pay for it because it's taken away what he's going to leave for me and my sister. And we keep saying, Dad, it doesn't matter.
But we've had 6 weeks now of awful, awful carers. We paid privately, getting a decent private agency in, and they were awful.
We had to tell him what to do when he started. He ain't got a bloody clue. It's like a swimming pool out there when he first got here. Well, we've got it down to fine art now. He don't do it.
Our carer came today and she's very good. In fact, I've asked, I would like Claire, if it's possible. But I'll tell you one thing, when you're blind, they don't put things back in the same place.
And I asked them that if they could get somebody just to sign to him. You don't send every day, you send somebody different.
It's a lack of communication with people, with authorities today. Because this one comes in afterwards, and well, the nurse has already been. Oh, well, I didn't know.
The future is obviously at my age with all the problems I've got. I shall, you know, pop off one day.
The future, I can do nothing about it.
Don't want to die? What else is there?
Yeah, it's something you've got to think of. Because it's going to come, whatever. We're all going to die.
I just want to live here till I can't go any longer and then just quietly slide off, you know. Power
of attorney is a godsend, I think.
you know, there are things that have to be passed on.
Take him and I said, buy your grave spot and your funeral place, and what would you like to do, and he's make his will.
When I've tried to have conversations about, you know, the death and the dying, she doesn't want to talk about it. I know, and you know, that talking about it might make it less frightening, hopefully.
I just want to get rid of this pain a little bit, that's all. I know I ain't going to get rid of it altogether because it's impossible.
The only time my legs are comfortable is if I'm sort of actually laying in bed and getting them right up level with me.
To get up, to go to the bathroom is absolutely agony. And I will sit here and think, no, I'll hold it for a little while.
If you took the Zimmer frame away from me in my front room at the moment, I'd be there. I'd be a statue all day long because I can't walk.
I mean, it's not just a lockdown. I've been in this home now for 2.5 years.
If things are working all right, I will go out and do my usual things. And that's why I look forward to my home when I come back. When you're in it 24/7, because your brain is bouncing off the walls.
I don't sit down all day. I get up and I move around.
You know, I can just about walk to the car or walk around the house without coming to any disaster.
I just wish I was physically more able to get around. Balance is a thing that bothers me quite a lot, and I'm nervous. I was losing my balance.
Because I have to concentrate so much on keeping upright.
See to it that he all right. The important thing is to know he eat and he keep clean.
The care of them come, them don't cook, but them warm up anything.
I do have ready news the last 18 months, I suppose. I can't get over the use of having to go to the toilet on a commode. It upsets me really. I don't know what it is.
One of the physiotherapists, she was absolutely wonderful. She gave me a chair for the bath that you sit in the chair and you pull the handle and it swivels round so you've got a shower.
What I find difficult that I can't control the shaking.
All I know, I take tablet until I tired.
I'm on injection now, that's not doing any good. I'm on drugs, that's not doing any good.
There's something in the medicine that is not working. That the scratching and the burning is not a good sign.
Nighttime can be a bit of a nightmare because there's a silence and there are things going through your brain.
And I think because you sit here so many hours thinking and thinking, yeah, it makes me so depressed.
I spent a long time wishing that I wouldn't wake up and put at least cut their misery in half.
You give a smile, then you feel that I'm better. That's the feeling that person has. But in fact, I may not be better.
This situation with the virus has added so much to everybody's anxiety, I think.
Who in this world don't worry? If you don't worry over one thing, you worry over other.
I've never been a depressive person, and put that down to prayer as well. And I think if you have a strong faith, that keeps you going.
I love my church, man, and feel like, no, I can't go. Yeah, you know, I mean, God, there are so many questions about it. Is there God or not?
I always think that God has got a purpose for me. And if I take my life too quick, I haven't served that purpose.
You know, and we sing and we pray together. You know, let him feel as comfortable as I can. I'm trying my best.
I've just started my life without my wife. I've got to think how I should live my life.
My lovely wife, we always hear one particular day, I might start crying now. And she said she died about half an hour, didn't she?
But she
wanted to die.
and she died where she wanted to be, with
Oh.
who she wanted, didn't she?
The dearest of all was no longer with me, but never mind. She's still around somewhere.
To think that I've lost my only brother, he's my only living relative that was a blood relative. Feeling sorry for myself, really.
And I miss him every day.
Went to see my wife's grave. I kissed the grave. It gave me good relief.
Life goes on, but you have to school yourself a bit to say this is where you are, make the most of it. It can always be worse.
There's always a silver lining of the cloud. Doesn't matter how bad it is, there's always a silver lining.
And I think a lot of it is mind over matter. But it's not easy for everybody.
There's things I can't do and I want to do, just to go back to the way I want to be. But I'm never going to get back to the way I want to be.
Yes, I can accept it, but not with good grace. But
I've got a lot of good things going for me. I really have. I've got a roof over my head. I've got Lily sitting on my lap. And, yeah, we are very, very fortunate.
So you've heard the voices of older people living with frailty who I and the team at St Christopher's have had the privilege to care for. And I hope that some of that is also resonating with so many of you who are already caring for older people living with frailty. But I want you to now take a minute to just reflect, and I want to ask you two questions. I want you to, first of all, what most stood out for you as you listened and you heard those voices and those stories? And the second question I want to ask you is, what does that film make you wish for? 2 questions. What most stood out for you? How did it make you feel? What most stood out for you? And what does the film make you wish for? So for those of you in the room, I want you to turn to someone next to you. I want you to share with each other. It's quite personal, this actually. Your responses, your thoughts to those 2 questions, and then we're going to share some of them together. If you're online, I'd really like you to put some of your responses in the chat. What most stood out for you, and what does the film make you wish for? Turn to someone. It might be someone you know, it might be somebody new you don't know. Okay, I'm going to bring you back together. There's quite a buzz in the room, lots of ideas and lots of thoughts. So can I have some volunteers who'd like to share some of those things that they've said? Let's hear from a few different people in the room. What stood out for you most, and what does this film make you wish for? There are 3 people with roaming mics. Pop your hand up if you'd like to share something with one of us. Great. I'll come to the front first. Yep.
I think what stood out for us was loss on a lot of different levels, really, as in loss of independence, loss of socialising, loss of physical ability, maybe health, just a lot of loss, but also some of the generation of the people that you were talking to sort of tried to, almost like the lady said, I tried to coach myself to pull myself together, and what that generation may do, but will future generations do the same? I don't know.
So a lot of loss on many fronts, and what did it make you wish for? One of the things it made you wish for?
I think possibly community and support, yeah.
Community and support. Great. Helen at the back.
Hi. What most stood out was that opportunity to yet again hear through their voices. And often we do presentations or find ourselves talking about that experience, and to hear it and see it is far more powerful. So thank you for that. That was certainly a great way of presenting. What does the film make you wish?
Yeah.
That I wasn't in the room hearing it again and again and again, that we actually had moved on from the years ago when we were all kind of aware that we were going to reach this, that again we're hearing through voices that the simple things still haven't been achieved, the communication, the same carer, listening to somebody's wishes, preferences, all of that.
So wish that we could enable this to move forward, that we could be part of making a difference. Yeah, a bit as we heard this morning about how you translate that thinking and those ideas actually into something that would make a difference in practice. Okay, have we got one from online? No? Okay, one more in the room. I can't see very much here. Do you want to give us another one? Yeah.
I was just going to say the same as the other lady. My wish is to put the finances and everything in, more finances to give the support, volunteers to give support for home care, because it's just loneliness and everything.
Finance and money, addressing
Staffing.
loneliness, staffing. Okay, any more? One more here. What stood out for you most? What does it make you wish for?
So it's actually just to build on what this lady in front of Angela said. What she was saying about putting money in for carers and for care, making sure people could be at their home and everything. I think there needs to be some regulations as well with some of the private caring agencies as well, to make sure that the same people are going in and at the level of care that they're getting is.
So there's a lot in there, wasn't there, about carers and continuity of care and what it feels like to be being done to, rather than doing with, which are very different things.
And it was, what stood out for me was isolation, and not just because of the COVID pandemic. It was just general isolation, being in their homes, not being able to go out and do things, which they then would later say that's what kept them going. Like the gentleman Morris, he really loved going to church, but he wasn't able to go to it.
Yeah.
So
yeah. And that comes back to again the loss, doesn't it? And some of the things that have been lost. Okay, one more, and then I'm going to move us on to the next question.
I think there's a bit for me that what stood out for me most is that I have not only a professional experience of this, but there's probably some people in the room as well who've got a personal experience of this. So there's a few of us who are at the stage where their parents are in this very, very fragile state of life. My mum died of frailty earlier on this year, so I had to try and separate my professional head with my daughter head, and I knew, working in a hospice, what good end-of-life care was, and it was that bit about, is my mum coming to the end of her life? Yes, she clearly is. Could I explain to the GPs and the nurses who were looking after her that she was frail and she was entering the terminal phase? Happened over Christmas and New Year, so it was difficult. I have to say that my mum had a very good death. You know, maybe a better death than she might have had in the hospice that I work in, because she was in her place, her own home. And so I think for me, I know that she had a good death, but to try to separate my professional head, that was difficult for me.
So really challenging there, isn't it?
Real challenge.
Many of our workforce, and I include volunteers in that, I include across the patch, both have personal experiences as well. And actually, as Helen said earlier, we are all heading to that point as well and thinking ahead about the future. Okay, thank you. I'm going to move us on. If it will let me. Okay. So I know that there was much more richness in the discussion that was happening. Keep hold of some of that. But I just want you to think a little bit now about what individually, many people here are coming from lots of different settings. You have lots of different roles in the organisations that you work in, and your setting, your structures will be very different to maybe where I'm working. But what for you as an individual, what for you in the team that you're placed in, and what for the system around you is the most important change, do you think, that needs to happen if we're going to radically improve the care of older people with advancing frailty? Okay, have a think. You might want to pick one of those. You might want to think about yourself individually. You might want to think about the team you're in, or you might want to think about the systems, some of the systems things that have already been mentioned. But what do you think is the most important thing that would radically improve the care of older people with advancing frailty? I'm not trying to suggest there's one answer, but what resonates with you? That's right.
Hi, I work in Jersey in the Channel Islands, and one of the things, we've got an aging demographic, and one of the things that we really need to be looking at and suggesting over in the mainland as well is looking at pathways. So if we can identify as a health system, wherever we are in the world, what frailty is. Okay, so Bob, my patient, saying he's frail, he's on a defined pathway. That then will reduce the inequities across the pathway, because if we know Bob then will have an advanced care planning discussion, Bob then gets access to the DS, we don't have them in Jersey, so gets access to an assessment, etc. And then he gets access to the specialist consultants that he needs to, and the specialist care, and the care is wrapped around Bob, rather than Bob's daughter or carer is trying to navigate a complex system. Systems are complex, they're complex even for us as healthcare professionals.
I wonder what role people in the room here would have to bring around them and to influence those pathways. I wonder who in your place of work you need to be integrating with, working alongside, communicating with, both across professions and across locations. I wonder for you what that might mean if you were going to be part of a solution to move that little bit forward where you are. One of the things I've really benefited from is something called an integrated care network, which I've had privilege to be part of, where actually a geriatrician, a palliative care physician, someone from mental health and someone from social prescribing with the community matrons, we meet together once a week, and the GPs phone in with some of their frail older patients for us to think together across the system. That wasn't there when I started at St Christopher's. That's something that has been put in place, not by me. I've just chosen to be part of it and to engage with it. You might have something different that would enable you to work and influence across the pathways. What else? Another idea.
Another idea is that we need to find another word for pathway if we work in palliative care, don't we? Because you can just feel the tension growing down here when someone says pathway. So that's the real challenge. Someone think of another word for pathway, and then we might be able to actually walk along one. But at the moment, we're stuck, aren't we?
Okay, so what other individual, this one down here, individual, team or system changes are most important to you that you think would improve things? Go on.
So I'm Rob Smith, I'm the Head of Service for Palliative Care in North Notts. I don't know if I've got colleagues in the room or not, but one of the things we're looking at is can we move care out of private agencies and into the NHS and use fast-track monies to fund it so that we can put care in earlier and individualise it a bit more around the individual. But I suppose the reason for that is because what we need in private agencies is a more governance around education provided to them, how they recognise deterioration, how they deal with distress, being able to not just put in 4 calls a day, but be able to go in and go, actually today you need 2, or let's start with 2 and we'll be comfortable with risk, but increase that and decrease it if we need to, all the work we can do around PHBs and so on. And I think, just while I've got the mic, I think the other thing, her name was Lola, is...
You've got 2 minutes, go.
Can we move from reactive healthcare into more proactive healthcare? So we have lots of falls teams that pick people up off the floor, but we don't do enough around how do we prevent things in the first place.
So a couple of things there. You've talked a bit about flexibility. Flexibility in an approach that would individualise care and would start with a person-centred approach, haven't you? You've talked a bit about trying to identify things earlier and put things that are proactive in place to prevent things from happening. But all of that requires some joined up working, doesn't it, across the system? And all of that isn't going to be for specialist palliative care to deliver, but it is going to be for us to have a role as part of it and to be coordinating and networking with others. And carers and care agencies, what points of contact do you have with people who are carers in the care system to influence, to encourage, to coach, to pull out the things that they do well. You heard a lot about the things they get wrong, didn't you? But how do we help to be part of the solution to build on the things that they do well? And also to start to maybe help to be part of the solution to address the things that aren't going so well. Okay, I'm looking out to see if I can see anyone else.
Mine's is an individual one actually, about the way that the world rallied around the pandemic to look after the frail elderly in our communities as neighbours and friends and family members, etc. So not from a system pathway, you know, hugely clinical perspective, but actually a lot of what I heard in that video was just about people that are looking for a relationship and that were lonely. And you know, for me, there's something about not the system. It's just about it being the right thing. So I lost my parents really young, and always I'm grateful I've never had to watch them be frail and old. So that was always the blessing for losing them while they were young and fit, that I didn't have to watch that. And as a result, I don't do enough for other people's parents probably who could do with, or people who maybe don't have children. You know, so there's something about the individual effort of it that's about everyone's business rather than it being about services and money and all of that stuff.
So something about communities. Sometimes about the network who is already around that person, or who could be drawn in to be around that person that is aside from the healthcare system. There's something there, as you've rightly said, individually, what can I do for the people around me, but also how can I be part of that societal change that actually starts to think differently about older people living with frailty and how we can be part of that community to support them. And I know for many of the hospices, we've got a big community action team. We've got a whole host of volunteers. It's not the part that I'm so embedded in, but we are so grateful to them for the initiatives that they are starting to take forward to build that within our communities. Okay, one more.
I just want to say one thing, Joy. One person on that film said, I think my mum would be better off not in my front room, but in a care home. And we haven't mentioned care homes as being part of a solution. We always see them as part of a problem. And I don't know if anyone here has any ideas about how they work or has any experience of how they're working well with care homes. Oh, look, there you go.
One in the middle. Yeah, go on.
So I'm a frailty clinical nurse specialist and I work with care homes, part of Hospice as well. And actually, they're doing some really fantastic work. They really are engaged. The idea of a home whereby they're all just sitting around watching television, God's waiting room, that's not reality. They've got some fantastic ideas. They've got things where they're bringing creches in, where they bring their children in. So it's like multi-generational. I've seen some real changes in people that were locked down in COVID that went into the home because they'd deteriorated, and they've actually improved because they've got that infrastructure around them, they've got people around them, they've got interaction. So yeah, care homes are not always negative.
So great to be part of that initiative that is encouraging that to move forward in a different way and is drawing a community in to be part of that support. Yeah. That's great. That's great. Any other ideas? I've got another one at the front here. I'll start at the back and then I'll come to you at the front. Yeah, at the back.
It's that one. I just wanted to expand on that theme. I think that we are all actually fairly scared of care homes from our own experiences, and care homes are changing, but I think that needs to be presented to the population as a whole, that this is not a care home, this is a place where you can make new friends, you carry on living, you do new things, you have new experiences. It's not a place to go to curl up in a ball and die, that this is somewhere where you go if you want those connections with new people, but we need to present that to the whole population so that there isn't this, I am not going into a care home over my dead body, do not let me go into a care home, that we see in couples, that actually it is seen as a positive and life-enhancing step towards the end of people's lives where they just need more help to do positive things.
And I wonder how we could get some of those stories where it has gone well out into the media, out into the general population, that we could start to influence that societal change. Can I just ask for a show of hands, how many of you or your team go into care homes currently? Okay, great.
And how many of you want to end your life in a care home? So that's what we've got to change, haven't we? A little bit. We need more books by Richard
That's
Osman.
4 hands then.
We need to change, we need societal change, and we need to get the word out there that actually we can't all die in a hospice, and if we're going to die in our own homes, it's expensive. So I'm with the lady at the back who says, we've been talking about it for a long time, where's the action?
Yeah.
And it's about to come, that's why I could say that.
Well, it is, except I've pressed the wrong button. I'm going the wrong way. Which way am I going? Other way. Not very well. And now I've lost it completely.
It's actually,
Okay,
I have to
so-
tell you, it's dementia training, that thing, because it's actually totally counterintuitive. You have to press it not the way that you think, which is probably very good for all of us.
Back
but
one more. That's it.
There we go.
Okay, back one more. They're doing it for me now. There you go. So, okay, so I want you now just to come back to yourself individually. You've heard some of the different things that have been said. And I want you to just now come off the fence and write down, you're not going to tell everyone else, what is the change that matters most to me? So the change that matters most to me is, and that's going to follow on with the action I will take. I will take individually, or I will take in my team, or I will take in thinking about how to move forward. There may be lots of things, but I want you to pick one. I want you to pick one that's going to have an action to it that you're going to take. If you're one of those people like me who needs to be accountable to someone else for it to happen, feel free to share that. But otherwise, come back to it. When you get home from the conference and you've got your list of things that have touched you, that have resonated with you, put that on the list of one of the things that you're going to come back to move forward.
There's a comment from somebody online. It feels like we should honour it.
Okay, yeah, so I have got a comment from online which says, again, in capital letters with lots of exclamation marks, we must ask the question, what matters to you right now? And I think as you listened to those stories, you could hear what mattered to those individuals. Probably wouldn't have been what I, as the doctor walking through the front door, would have thought was the thing that was going to matter right now. And we've got to then try to facilitate those services to address that. Okay, Kat, I'm going to hand back to you.
I've waited a long time to say this. Next slide, please. So it falls to me to bring the session to a close, but I wanted to start that few minutes by bringing us back to the title of the session, What's in it for us? Why should we care about the care of people with frailty? So this question, as we no doubt have worked out, will mean different things to different people, depending on whether you take the perspective of a child, or carer of someone who's older, a funder's perspective, a clinician's or volunteer's perspective, or from the perspective of someone living with frailty, such as those we were lucky enough to see in that video. Understanding the what's in it for me question is a central tenet of change management and quality improvement. So it's critical we know the answer if we're to elicit and embed meaningful and sustainable change and improvement. I put it to anyone listening, though, that there's a rare person among us who won't have a ready answer. And there is a very real urgency to getting on with improving our offer to people with frailty as we face the changing and evolving patient need. So our humble call to action to you. We invite you now to take forward your thoughts and questions, and ideally some next steps to implement changes that could radically improve the care of people with advancing frailty. As final thinking points, we ask you to consider that our established prediction tools don't do so well when we apply them to the care of people who have frailty. These patients may deteriorate, but they're also capable of unexpected and remarkable recovery and rehab. These people will keep us on our toes and require us to do even better than we do already. But we do have these skills. Jason Leach said this morning that we have patient-centred care nailed. The building blocks of good quality care at end of life for which we can take pride in ourselves, such as discussion, planning, symptom control and bereavement support, are all the same no matter the cause of death and should be available to everyone. In palliative care, we are known for understanding the value of extended networks, and the importance of informal carers cannot be understated in the care of people with frailty. And also in palliative care, we know individualised care is going to have the best chance of success if it is part of an advanced care plan. Next slide. So you'll have seen this already, but we were very proud of this slide earlier. And I'm not going to read it all, but I will say this. Frailty is everybody's business, as somebody actually said earlier in our conversation. And we really mustn't let it end up that everybody will be blaming somebody when nobody is doing what anybody could do. Finally, I would like to thank the people on the panel alongside me, Helen King, Dr. Joy Ross, Dr. Julie Kinley. I'd also like to mention Dr. Sarah Coombs, who sadly couldn't be here today, but she contributed, and to Stuart Duncan for his tireless work in behind the scenes to get the session organised. But most of all, I'd like to thank the people who shared their voices in the video and those that helped them to make it. Thank you.